Now, that poses the question whether we are indeed neglecting the small fibers in our patients. I would like to point out, though, that this was an animal model, and obviously it's difficult to say whether that translates to what we see in our patients. So what we did is we actually did that study, and we used carpal tunnel syndrome as a model system to look at it. Now, obviously, I can't cut out the median nerve in these patients, but what I can do is I can take a skin biopsy in the median nerve territory. And as you all know, a substantial proportion of our sensory fibers start and end in the skin. So therefore, the skin biopsy is a great window that allows me to look into the nervous system. And when we did that, we first looked at the large axons. So I quantified the number of Meissner corpuscles. Meissner corpuscles are the receptors of the large myelinated A beta fibers, so the touch receptors. And as you can see, we did not find a significant loss of these large fiber receptors. Similarly, when we quantified the number of myelinated dermal fibers, we could not find a significant loss of the myelinated fiber population in patients with carpal tunnel syndrome, further suggesting that the large axons remain spared. However, when we looked at the small fibers, it was a really different story. And I would like to show you here, this is a skin biopsy with the dermal layer at the bottom and the epidermal layer on the top. And we know that those fibers in red that penetrate into the epidermal layer are exclusively small fibers, because the large fibers never penetrate into the epidermal layer. Now, we did that, and that is an age and gender matched patient with a carpal tunnel syndrome, and you can already see visually that he has a significant fallout of the small fiber population in the skin. And when we quantify that, that was significantly a significant downregulation of that small fiber population in the skin. And I would like to highlight that this was completely independent of the electrodiagnostic test result. For example, there was one patient with a very mild electrodiagnostic carpal tunnel syndrome, but he had almost no small fibers left in his skin. And that is not surprising, because electrodiagnostic tests purely test the large fibers and do not say anything at all about what happens to the small fiber population. Now, obviously, the question is a bit, if patients have this small fiber degeneration, what happens to them? Can they actually regenerate, for example, if they have surgery? And that is what we are currently looking at, and I would like to show you some preliminary data, which is quite intriguing, I think. So if we have patients with carpal tunnel syndrome and they get operated 3 months, when they come back, there is not an awful lot of regeneration as yet. However, at 6 months, there is at least partial reinnervation of the small fibers into the skin. Interestingly, though, if patients have no surgery, they continue to show a loss of these small fiber population over time. And even though we don't know exactly as yet whether that is the truth, but that makes me think, even if it's a simple carpal tunnel syndrome, maybe we have to start thinking, how long do we really want to leave those patients before they get treatment? Now, at the 6 months time point, I would like to show you single patients, pre and post-surgery. And what I would like to point out is that there is a significant variation in the regeneration capacity of our patients. In orange are those patients that even that they had surgery, they continue to degenerate in their small fibers. And we are currently looking whether that might explain why some patients with a lower regeneration capacity do not benefit from surgery. Most importantly, we're currently looking at the genetic profile in the skin, the expression profiles in the skin, to see whether we can find a molecular signature that might facilitate or prohibit regeneration. Now, for you, what might be of interest is that we also had some patients with completely normal electrodiagnostics in our patient cohort, and these are the ones. And as you can see, a significant proportion of these patients actually had an actual structural loss of their small fibers. So that makes me really think that it is insufficient to solely rely on tests for the large fiber integrity. How can we test that though in clinics? And I'm not advocating that you're taking skin biopsies, obviously, but there are other tests that we can do in clinics. And quantitative sensory testing is something that has become quite fashionable over the past decade, and quite commonly it is used in a neurological setting. And we actually confirmed that quantitative sensory testing is able to pick up this loss of small fiber function. As you can see here, patients with carpal tunnel syndrome have significantly more difficulties feeling cold and warm stimuli, which are mediated by A delta and C fibers respectively. Now, again, you might not have access to these kind of thermal stimulators in your clinic. So the question is, can you use a very simple tool to test the small fiber population, where we looked at the sensitivity and the specificity of such very simple tests for cold thresholds and pinprick thresholds for A delta fibers to look at whether we can pick up such an actual loss, a structural degeneration of those fibers compared to the gold standard of the skin biopsy. And as you can see, the sensitivity is rather shocking, I would say. However, the specificity is really good, meaning that if a patient has indeed a problem feeling cold or feeling pinprick as sharp, it makes it highly likely that he has an actual structural loss of the small fibers. If you have a negative test, though, you can't say that this patient doesn't have a small fiber degeneration. Now, there's a lot more work needed, and we are currently looking at a multi-center study together with Brigitte Tampin in Australia, Karina Böttger in Switzerland, and in Oxford at these tests in relation to the standardized quantitative sensory testing. And I hope we can tell you more about these tests in a couple of years, because it's really important that as clinicians, we have simple bedside tests to test these small fibers, because we just simply can't afford to neglect 80% of the fiber population in a peripheral nerve.